Plasma cell disorders. So for NEET super specialty, very important topic, myeloma and other plasma cell disorders. So we'll be discussing in detail. Okay. So plasma cell disorders are basically neoplasms of this monoclonal neoplasms of the plasma cells, right? So these plasma cells, they develop from the common lymphoid progenitor. They eventually commit to the late B cells, then from that plasma cells. So neoplasms of the plasma cells, right? So there are multiple myeloma, Waldenström macroglobulinemia, amyloidosis, heavy chain disease. All these are can be grouped under this plasma cell disorders, right? So monoclonal gammopathies, paraproteinemias, plasma cell dyscrasia, dysproteinemias, all these are synonyms for this, right? So this monoclonal gammopathy, meaning the plasma cells produce the monoclonal proteins which are creating problems, right? So before going to that, the structural variations of immunoglobulin, basically there are three categories of this antigenic determinants, right? So there you have to familiar with these words: isotypes, allotypes and idiotypes, right? Isotype, basically this distinguish between the classes of antibodies, okay, of a given species. It and are the same for all normal individuals of that given particular species. So isotypic determinants are basically determined as recognized by the antibodies from a distinct species. So there is particular for a species, heterologous sera, but not by the antibodies for, from the same species, homologous sera. 5 heavy chain isotypes, 2 light chain isotypes. So MGADE, these are isotypes, and light chain kappa and lambda, right? And allotypes, meaning regular small differences between the individuals of the same species. In the amino acid sequence of otherwise similar immunoglobulin, there are minor immunoglobulin variations in the same species, right? These are determined by the allelic gene. So different alleles code for different proteins. So by definition, they are detected by antibodies made in the same species, right? And idiotypes, these are unique molecule produced by a given clone of antibody producing types cells, and these are formed by unique structure of antigen binding portion of the molecule. So allotype, isotype, allotype and idiotype. So isotype, this major categorization into IgM, IgG and kappa lambda light chains, these are basically the isotypes. And of the there is a minor allelic gene mediated variations in small molecule amino acid variations, these are called the allotypes, right? So these are the 5 antibodies: IgG, IgD, IgE, and IgM, as we all know, it's a heavy molecule, pentameric molecule. IgA is a dimer, and which is the secretory immunoglobulin, right? So how do these immunoglobulins are? There are various immunoglobulins formed. These are basically, to start with, the B cell ontogeny. That class has been already been covered inside the when we discussed the non-Hodgkin's lymphomas, the B cell ontogeny. So you can refer to that lesson also. So there is something called a VDJ, that is a heavy chain, and the VJ joining of the light chain. So VDJ recombination, gene rearrangement, give rise to the biodiversity. In the combinations can be n number of possibilities, so that according to the antigen stimulus, there are this VDJ recombination. After exposure to the antigen, variable region may become associated with a new heavy chain isotype. Class switch happens. So VDJ gene rearrangement, then somatic hypermutation, and the class switching. These are the steps where we get the antibody specificities, okay. So light chain are synthesized in light excess and secreted a free light chain and cleared by the kidney, but less than 10 milligram of such light chain is excreted per day, right? So before moving on to topic per se, just few discussions on the electrophoresis. Basically, electrophoresis is to separate the serum protein. So this is a serum protein electrophoresis. There is hemoglobin electrophoresis also, which we do in this, which is also HPLC, that is a high performance liquid chromatography, that is for the hemoglobin. So it is to separate the hemoglobin as per the mobility. Just like that, protein also is separated to components various as per the molecular weight, right? So IgG move heterogeneously in electric field and form a broad peak at the gamma region. So alpha region, beta region, gamma region. So it as per the mass, molecular mass, it moves and forms a band in the corresponding region. So immunoglobulin basically in the gamma region. Gamma stands for immunoglobulin region, usually occurs at that. And there is a sharp spike in this region called the M component. M stands for monoclonal, that's why the name, right? And less commonly, it can appear in the beta 2 or alpha 2 globulin region, especially if it is an IgA protein, right? immunoglobulins could be IgG, IgM, IgA, IgD, IgE. So IgA usually tend to migrate or in the alpha beta 2 regions, right? If you have an M band in the beta 2, it could be a IgA protein, right? Less commonly, and monoclonal antibody must be present at the concentration at least 0.5 gram to be accurately quantitated by this method. 10 to the power 9 cells producing antibody. So so M band, basically this is the monoclonal which give a quantitative assessment of the protein, quantitative. Now if you get an M band, what you do is a IFE, immunofixation electrophoresis. Okay, so immunofixation electrophoresis, we type this M band. Say if you get a 3 gram per deciliter, you type this. How do you type this? You have to identify if it is an IgG type or IgM type or IgA type, okay. Along with the, you do a free light chain assay, okay, FLC assay, where you get a quantitative kappa lambda and you get a kappa lambda ratio, okay. So this is how the M band serum protein electrophoresis SPEP. SPEP will give you the M band quantitative. Now you qualitatively you can identify this whether it is IgG, IgA, IgM, okay, and along with the free light chain quantification kappa lambda ratio, you can get to know which is the heavy chain, which is the light chain, and how much of protein is present, okay. So this is the graph. So here you can see this is the IFE graph, which is normal graph. There is no monoclonal protein, this could be a polyclonal, and there is a polyclonal, there is a dense this in all across IgA, IgG, lambda and kappa we can see. This is a polyclonal increase which we can find in infections. But here there is a clear cut, a band is formed in the IgG region, which is these three are the heavy chains and these two are the kappa lambda light chains. So you can see there is a lambda band which is not present here, we can't see as a band, okay. Here IgG also we can see a band here like this, and nothing is there in the other, so this is called a monoclonal IgG lambda, okay. So other polyclonal, it could be infection, okay, and monoclonal gammopathy single cell produce a church spire. So this classical church spire appearance, this is the M band, right. So here there is no band, here there is a polyclonal, there is a diffuse spreading, and here there is a definite M band. This is a church spire, just like a church spire, okay. And this, if this is a quantitative, you get a quantity, and here it is a qualitative, which all bands, okay, IgG, IgA, IgM, kappa lambda. So you get a spike in the IgG and the lambda region. So M components, is it seen only in myeloma? No. Neoplastic, it can seen in CLLs, it is a B cell lymphoproliferation, they can also present with a monoclonal protein. Lymphomas, non-lymphoid neoplasms like CML, breast and colon cancers, even though very rarely. And non-neoplastic, like in cirrhosis, sarcoidosis, parasitic disease, gouches, pyoderma gangrenosum, autoimmune conditions like rheumatoid arthritis, myasthenia gravis, cold agglutinin disease, organ transplant, rarely post-transplant, allogenic transplant, skin diseases, especially you have to remember lichen myxedematosis, also called papular mucinosis, and necrobiotic xanthogranuloma. So this chart can give you one-liners or MCQs, which all conditions are associated with the M component. Okay. So moving on, 20% of myeloma, only light chains are produced. So there is something called, not all myelomas will be having a heavy chain. Okay. So there are a fraction of myelomas, that is 1/5, that is 20% of myeloma, there might be only light chain. So light chain, the problem is, this can be secreted in the urine as Bernstein protein, but Bernstein protein assessment nowadays is being obsolete because there are more sensitive assays. So if you have a light chain myeloma, so it may not be seen as in M band. So M band may be negative. This is a very important point. M band negative could be negative in light chain. Why? Because light chains have a very short T-half, right? They are rapidly eliminated. So there is no time to mount and to present in a M band region. Light chain may not be there. So if M band is negative, you cannot exclude a myeloma, right? So for that, you have to do a total profiling immunofixation electrophoresis, including a free light chain assay. Okay. So my M band may be negative, and in immunofixation, you may see IgA, IgM all are negative, and kappa lambda you can see only a lambda. So that is a lambda light chain myeloma. So what I would suggest is, if you have a M-band negativity, if it's a strongly suspected myeloma, other CRAB features are there, you have to rule out a light chain myeloma by doing a free light chain assay. Okay. And myeloma is basically by definition is the proliferation of the plasma cells, basically a monoclonal cell, that is a monoclonal plasma cell proliferation. And problems arise from the tumor itself because it expands the marrow, bone damage can happen. Then secondary to this protein, that is the monoclonal protein synthesis, it can be deposited in the kidneys causing renal failure. And the total immunity is lost, immunoparesis, it can lead to infections and other problems. And bone damage by direct marrow infiltration, hypercalcemia and leak of calcium into the system. Okay, so this anemia due to the marrow infiltration, right? So hypercalcemia, renal failure, anemia, bone pain, fractures, susceptibility to infections, occasionally due to high protein load, clotting, hypercoagulability, clotting abnormalities, neurological symptoms and manifestations of hyperviscosity. So primarily due to the plasma cell proliferation, that tumor load can have plasmacytomas, bone fractures, etc. Calcium may leak out and anemia can occur due to the marrow replacement, and the protein load will lead to the renal failure and hyperviscosity symptoms. So like that. And etiology wise, exposure to radiation, nuclear warheads, farmers, woodworkers, leather workers exposed to petroleum products, but these are could be, there's a possible association. Okay, recurrent alteration, hyperdiploidy, trisomy is involved, one or more chromosomes is observed in 50%, and 14 gene, again this is the IGH, heavy chain gene. So this chromosome, when there is a translocation with other proliferative partners including 11, 14, 4, 14, okay, then 14, 16, all these can lead to high risk myelomas. Other abnormalities, 13q deletion, 1q amplification, 1p deletion, 17p. Okay, NRAS, KRAS, BRAF mutation in more than 40%. Okay, so depending upon this, we can prognosticate the myeloma also. Incidence increases with age, median age 69, uncommon under age 40, males more common, blacks nearly twice. Okay, pathogenesis. So basically myeloma, the cells have a cell surface adhesion molecule to the bone marrow stromal cells, that is stromal cells via the cell surface adhesion molecules, the cells bind to that and triggers the cell growth, survival, drug resistance. Direct this binding via adhesion to induce other cytokines are released due to this adhesion like IL-6, IGF, VEGF, stromal SDF1A. Then growth and resistance are mediated through the RAS and MAP kinase pathway, PA3 kinase and protein kinase C. So basically there is attachment, adhesion molecules, various cytokine release, and then this various downstream pathways are activated. Endothelial cells and osteoclasts. Okay, basically this is a bone microenvironment, right? And immune cells such as plasmacytic dendritic cell, myeloid derived suppressor cells and T helper 17 cells are increased in number and support the myeloma growth. Okay, so basically this milieu supports the growth of myeloma cells, but various interactions between this adhesion molecules, various cytokine and the microenvironment also protects due to the activation of the downstream pathway. Clinical manifestation, bone pain is the most common, affecting 70%. Localized pain significant, may signify fracture. Okay, and bony lysis due to substantial mobilization of calcium, hypercalcemia. Okay, and localized bone lesion, like if you have a plasmacytoma or a fracture, it can compress on the spine and cause a hematological urgency, so that it has to be dealt very immediately with either starting steroids, radiation or decompression, right? Bone lesions are caused by the proliferation of the tumor cells and activation of osteoclast and suppression of the osteoblast. Okay, osteoclast, osteoblast. Okay, these are activated, osteoblast are suppressed. So basically towards the destruction, and it is mediated osteoclast activating factors. And bone lesions are lytic in nature and rarely associated with the osteoblastic due to the suppression of DKK1 produced by the myeloma cells. Next is infection, susceptibility to infection, especially pneumonia, pyelonephritis, frequent pathogens being staph pneumonia, staph aureus, Klebsiella pneumonia, other gram-negative in the urinary tracts. So 25% will have recurrent infection due to the immunoparesis, because only one monoclonal protein is formed, it is of no use. At the same time, the useful immunoglobulins are not formed. This is called immunoparesis, right? Diffuse hypogammaglobulinemia if M component is excluded. So, you have a monoclonal protein that if excluded, you have a immunoparesis. Other normal immunoglobulins are not formed, and decreased production and increased destruction by the normal antibodies. So, large M component result in a catabolic rate increase 8 to 16% instead of normal 2%. So, normal fractional catabolic rate is 2, when in myeloma 8 to 16%. Okay. Then other circulatory regulatory cells can suppress the normal antibody synthesis also. Other abnormalities in T cell function and complement function can also occur in myeloma. Because also if we start treatment, like most of them are immunosuppressive like steroids, bortezomib, all that can contribute to the totally the immunoparesis can be contributed by the medications used in the treatment also. So, bacterial infections and fungal infection can be precipitated by DEXA, BCMA CAR cells, hypogammaglobulinemia, and bortezomib herpes virus reactivation. That is why whenever you use a bortezomib based regimen like Cybody or VLD, you give prophylaxis with the acyclovir. And clinical manifestation, renal failure, continuing clinical manifestation, 25%, 1/4 will have renal failure, some renal pathology in more than 50%. So, even if it is not overt myeloma, there is something called a MGRS also, monoclonal gammopathy of renal significance also, especially in myeloma, smoldering myelomas or other B cell proliferative disorders. Hypercalcemia is the most common cause. So, most common cause of renal failure is hypercalcemia. Other include amyloid deposition, hyperuricemia, recurrent infection, NSAIDs used for pain, iodinated contrast for imaging, bisphosphonate use, infiltration of the kidney very rare, and tubular damage associated with excretion of light chains is almost always present, because light chains are excreted in the kidney, so they can deposit and they can form amyloid or any of these above mentioned causes. Anemia usually normocytic, normochromic. Okay, many of them come for evaluation of anemia. It could be due to myeloma, and replacement of the normal marrow by expanding tumor cells is the cause. And hematopoietic by the factors, this tumor secreted factors suppress the normal hematopoiesis, and this also there is decreased production. These are the causes for anemia, and effects of long term therapy like anemia of chronic disease. Hemolysis may contribute to anemia, and megaloblastic anemia due to folate or B12 deficiency associated. Okay, so all these can contribute to anemia. So, causes of anemia in myeloma, like I mentioned, these are multifactorial. White cell count drop and thrombocytopenia are rare but can occur. Even I have a few patients with pancytopenia presentation, they are due to myeloma. Clotting abnormalities due to failure of anticoagulant clotted platelets to function properly. So, platelet function disorders can occur, especially in the advent of very huge M protein, and this M protein can interact with the clotting factors and cause an acute kind of a like a coagulation disorder. Also, amyloid can also damage to the endothelium. DVT, especially when we use thalidomide, lenalidomide, this IMiDs can cause, and steroids can predispose to development of deep vein thrombosis. Raynaud phenomenon, especially if the M component forms the cryoglobulins, and hyperviscosity syndromes may, depending upon the physical properties of the M component, this kind of presentation can also be seen. Normal relative viscosity 1.8, if viscosity more than 4 centipoise, which is usually reached if the protein concentration more than 4 gram for IgM, 5 gram for IgG3 and 7 gram for IgA. So, hyperviscosity, usually the normal is 1.8 centipoise. If it is more than 4, usually happens with the these cutoffs IgM 4 gram, because is when compared to the IgG and IgA, this is a heavy protein. So, smaller amount is required, 4 gram, whereas IgG it is 5 gram and IgA it is 7 gram. Neurological manifestation, causes for neurological, one is hypercalcemia, hyperviscosity, bone damage, infiltration, neuropathy. So, hypercalcemia, lethargy, weakness, confusion, seizures also confusion. Then hyperviscosity again can present with headache, fatigue, shortness of breath, precipitation of heart failure, visual disturbance, ataxia, vertigo, retinopathy, somnolence, and even coma. Bone damage, collapse, cord compression, which is an emergency, we have to intervene immediately, radicular pain and loss of gallbladder involvement. Infiltration of peripheral nerve, again amyloid can infiltrate the nerves, carpal tunnel syndrome can occur, other sensory motor neuropathies can, and even secondary to drugs used like bortezomib, thalidomide, the neuropathy can even occur, right. So, drugs like thalidomide, sensory neuropathy. So how do you diagnose and stage? So MGUS most commonly in myeloma. So MGUS more common than myeloma, 1% of population more than 50 years, up to 10% in up to 75. So it can be a progression from monoclonal gammopathy of MGUS progressing to a smoldering myeloma, then progressing to overt multiple myeloma. Okay, MGUS is just protein, smoldering is higher load of protein, myeloma is CRAB plus myeloma defining event manifesting as symptoms or disease. So you have to treat here. These will progress to this, so we have to monitor this. 1% of the patients per year MGUS go to development of myeloma. So this progression per year, this can also be included in can be asked as an MCQ also. 1% progression by in MGUS. Non-IgG type abnormal kappa lambda free light chain ratio, serum M protein more than 1.5 gram are associated with higher incidence of progression. So absence of all these features. So any of this, there is more chance for progression. The rate of progression is more. So all absent 5% progression, and whereas higher risk with all these three features 60%. So 5% versus 60% in the depending on any of this is positive. So that is non-IgG type, abnormal kappa lambda ratio, serum M protein more than 1.5 gram. So any of this, none is present, 5%, all of this 60%. So that is the difference. So high risk of progression from SMM to myeloma is bone marrow more than, plasma cyto more than 10, kappa lambda ratio abnormal, and protein more than 3 grams. So here to here, here to here, they have identified the features for progression. Okay, so as per definition, Mayo Clinic are the pioneers in myeloma. So basically the International Myeloma Working Group classification, MGUS, especially non-IgM, is M protein. This is very, very important. Okay, you have to be clear about the classification or the diagnostic criteria of the myeloma and other plasma cell disorders. So MGUS is less than 3 gram protein, less than 10% clonal plasma cell, no CRAB. Okay, so nothing. Less than mild protein, monoclonal protein is there, but uncertain significance. So less than 3 gram. Then this plasma cell less than 10%, clonal plasma cell, and no CRAB or myeloma defining events. That is MGUS. So coming to the smoldering, they are much bigger. So they have a higher protein load. So more than or equal to 3 gram of protein, or urinary monoclonal protein more than 500 milligram per 24 hours. Okay, and plasma or plasma cytosis in clonal plasma cytosis between 10 to 60%. But no CRAB or amyloidosis. Okay, no end organ damage, no amyloidosis, but urine protein or serum protein is more than 3 gram. Okay, and 10 to 60% clonal plasma cytosis. Coming to the overt myeloma, we all know more than or equal to 10% or biopsy proven bony or extramedullary plasmacytoma. So clonal more than 10 plus you have a end organ damage. That differentiate SMM from myeloma. So any one of the end organ damage, we know the CRAB, hypercalcemia usually more than 11, okay, renal insufficiency, creatinine more than 2, or creatinine clearance less than 40, or creatinine more than 2. Anemia, hemoglobin value more than 2 gram below the lower limit of normal, or HB less than 10. Bone lesion, 1 or more osteolytic lesion at least 5 millimeter, that you have to remember. At least 5 mm, 1 or more osteolytic lesion in CT, PET or MRI. Okay, and there are 3 myeloma defining events. Okay, so why this was added? Because we used to miss if M band is negative, because till now classification is mainly based on the M protein. Now we know that from the earlier slides, there are 20% of the cases are light chain myelomas where M band will be negative. So when you screen M band, if it is negative, you can't rule out a myeloma because there is something called a light chain myelomas. So this was identified. So they included a myeloma defining event also, because these light chain myelomas eventually later will present with CRAB and all. So then its very precious time is lost, right? So the myeloma, 3 myeloma defining events. One is if clonal plasma cells more than 60, it is straight up myeloma. More than or equal to 60% clonal plasma cell, it is myeloma. Involved versus uninvolved free light chain. This is to include the light chain myelomas more than or equal to 100. Say if kappa kappa lambda ratio is more than 100, then it is straight up myeloma, and more than one focal lesion in MRI at least 5 mm size. Okay, these three has been included in the what you call as a myeloma defining event. So, and plasma cell leukemia, more than 5% or more of plasma cells in the peripheral blood. Okay, then other criteria of myeloma plus peripheral blood, if you get 5% of circulating plasma cell, then that is plasma cell leukemia. So, these are the various MGUS, more severe is SMM, then myeloma with myeloma defining events, then you get the plasma cell leukemia. Okay, then for IgM, that is the this IgM MGUS, basically the protein same as less than 3 gram protein, less than 10% lymphoplasmacytic infiltration, again no CRAB, plus there is no hyperviscosity, lymphadenopathy and hepatosplenomegaly, because it is IgM monoclonal and IgM MGUS, you have to take care of it. Is a lymphoma like presentation, so no hyperviscosity, no lymphadenopathy, no hepatosplenomegaly. Light chain MGUS, again abnormal FLC 0.26 to 1.65, the range beyond this, and increased levels of light chain. Okay, then no immunoglobulin heavy chain expression, that is the light chain MGUS. So, there is a light chain protein but no CRAB symptoms and all. Oh, no end organ damage, clonal plasma less than 10%, monoclonal protein less than 500. Solitary plasmacytoma, basically all 4 criteria to be met, one single solitary plasmacytoma. Biopsy proven plasmacytoma, normal marrow, no evidence of plasma cell, normal skeletal survey, except for that particular lesion, no one else, and no CRAB feature. So, it is not myeloma, only one single lesion which is biopsy proven. Solitary plasmacytoma. Something called a solitary plasma with a minimal marrow involvement, that is all 4 to be proved. Similar to the other one, but clonal plasma cells less than 10%, normal skeletal, no end organ damage. Okay, so these minor differences are there. So, this is a normal marrow. This here you can see the plasma cells, round or oval cells with eccentric nucleus composed of closely chromatin, densely basophilic cytoplasm, perinuclear clear zone, Golgi apparatus, binucleate and this multinucleate plasma cells can be seen. Just a visual comparison. So, evaluation SPEP, as I said, IFE and measurement of immunoglobulins and free light chain, that completes the protein analysis. 24-hour Bernstein protein nowadays being obsolete. M component, usually IgG more common than IgA than IgD. 20% only have, as we said, this already mentioned, and heat test for Bernstein falsely negative in 50%. That is why it is becoming obsolete, because we have other specific tests like light chain assay, in serum free light chain assay. 1% have something called a no M-band, and these have light chains myeloma, in which renal catabolism usually, why there is this M-band is not there in light chain myeloma, because very rapidly cleared, it may not mount as an M-band. IgD myeloma also present with light chain disease, and 2/3 of the patients with serum M compounds also have urinary light chains. Okay, and among the IgG3 has the highest tendency to form and concentration temperature dependent aggregates to form hyperviscosity and cold agglutination. So, IgG3 of the IgG3. Okay. And smear, you have to look for plasma cell leukemia also, and type of anemia, Roux formation, plasma cells more than 2000 absolute plasma cells is plasma cell leukemia. ESR elevated, calcium elevated, creatinine elevated in overt myeloma, means all may not be there. These are the things you should look at. Alkaline phosphate, especially in case of a fracture or extensive marrow, skeletal involvement, can be elevated. Beta 2 microglobulin albumin for prognostication. X-ray for lytic lesion, MRI, then PET. Nowadays PET is more sufficient, so to rule out whether it's a CT component, will look at the lytic lesion, and if there is a soft tissue component, that is also can be picked up. Okay, then evaluation, again bone marrow aspiration biopsy, histology and clonality, because you have to check for the percentage of the clonal plasma cells that you can assess either by flow cytometry or by a IHC. Investigation, this already we have discussed, and hemogram, I think we have already discussed. Then for prognostication, one more thing, we have to do a FISH test to look for hyperdiploidy, like with karyotyping, to look for the high risk markers. This will prognosticate. How do you prognosticate? This is basically by the ISS scoring, revised ISS. So, serum beta 2 microglobulin, albumin, cytogenetics by FISH and karyotyping, and LDH. These are the 4 things you have to take in consideration to assess the ISS. Okay. So, if beta 2 microglobulin less than 3.5, stage 1, more than 5.5, stage 3, anything in between falls into the stage 2. Albumin more than 3.5, okay, then stage 1, and along with the beta 2 microglobulin, no high risk cytogenetics, normal LDH. So, when coming to the high risk, if it is beta 2 more than 5.5, high risk cytogenetics by FISH, high LDH. High risk cytogenetics meaning 414, 14, 16 and 17p, right. So, Mayo Clinic's MSPART classification, again an MCQ, standard, they are classified into standard risk and high risk. Standard risk include trisomies 11, 14 and 6, 14, and high risk all this 4, 14, 14, 16, 14, 20, 17p, gain 1q. Double hit lymphomas, any high risk features you call it double hit, and triple hit you call any 3 or more is high risk. So, there is not just DLBCL, we have a double hit myeloma and a triple hit myeloma if there are 2 or 3 high risk factors. So, high risk factors 4, 14, 14, 16, 14, 20, 17p and 1q gain. Okay. Treatment of MGUS, usually it is to be observed and no specific intervention, once in a year or even 6 monthly you can observe. Then MGUS plus severe polyneuropathy, if there is you presume that this is a cause, no other causes has been elucidated, then plasmapheresis and occasional rituximab in IgM MGUS or myeloma-like therapy in IgG or IgA disease. Okay. Then something called monoclonal gammopathy, renal significance. This is M protein is the renal involvement. There are various deposits, amyloid, fibrillar deposits and all. They can cause, they sometimes need to be addressed. It can cause MGRS may present as in the background of myeloma or monoclonal gammopathy of unknown significance, also in background of other low-grade B-cell lymphoproliferative disorders also. Smoldering and solitary plasmacytomas, 10% is smoldering, indolent course many years, it can just be observed. In smoldering myeloma, no specific indication, but it has to be followed up. But in high-risk smoldering, we can even add lenalidomide dexamethasone based therapy. Okay. So, solitary plasmacytomas and extramedullary plasmacytomas usually give RT, especially if they present with a spinal fracture or a solitary compression of the spinal cord. It has to be dealt immediately with either a decompression surgery or a radiation along with steroids or myeloma therapy. Okay. NCCN guidelines, smoldering myeloma, low risk, just observe 3 to 6 monthly, high risk, clinical trial if available preferred. Or you can even observe, or if you deem it or the patient after discussion, if you want to treat, you can add lenalidomide based therapy, and you have to follow up every 3 to 6 monthly. Okay. And coming to the overt multiple myeloma, mainly there are 3 important. So, these are the myeloma meaning end organ damage or myeloma defining events with either more than 60% clonal plasma cell or more than 10% with the crab features, right. So, 3 agent immunomodulatory drugs, proteasome inhibitor, targeted antibodies. So, usually nowadays the era of even upfront we can give quadruplet in young patient, fit patient, or at least triplet is the standard of care. Earlier there was doublet also, especially if elderly you can go with a doublet like lenalidomide dexamethasone based. So, these combinations of these 3 groups are used. Immunomodulatory being pomalidomide, lenalidomide, all the age or thalidomide. Proteasome inhibitor, bortezomib, carfilzomib, etc. Targeted antibodies like daratumumab. These 3 can be combined along with the steroids, that is dexamethasone. Okay. So, doublets meaning 2 of these, triplet, quadruplets, right. So, 4 to 6 cycles of these combinations are initially used to achieve remission. Okay. So, you monitor with the M band or your light chains. Okay. So, you give at least 3 to 4 cycle you give, then you assess, and if it is in at least PR. So, if it is a VGPR, then well and good. CR, there is something called CR, VGPR or PR, meaning M band if initially from their 100% reduction, then it is called CR with absence of immunofixation. That is stringent CR, VGPR meaning 95% reduction, PR meaning 50% reduction. So, we can assess like this with the protein. then plan further treatment. So these are the group of drugs. This is a snapshot from the Harrison table. You can go through because it's a big table. You can go through the details. Immunomodulator like thalidomide, lenalidomide, pomalidomide, proteasome inhibitor, borti, carfil and ixazomib. Ixazomib being the oral one. So oral proteasome inhibitor is ixazomib. Antibodies like daratumumab targets anti-CD38, elotuzumab again isatuximab, belantamab mafodotin, and selective sign inhibitor like in DLBCL it is used, selinexor, histone deacetylate inhibitor, penabinostat, alkylating agents like melphalan which is also used as a conditioning for autologous stem cell transplant, cyclophosphamide, bendamustine, melflufen, cellular therapy that is a CAR cell therapy. CAR cell therapy, idecaptagen, viclucal. Basically in CAR cell therapy in myeloma it targets the BCMA. Okay. So basically in CAR cell for B cell neoplasm like CD19 CARs are used in B cell like BALL, refractory BALL or like a refractory DLBCL or other B cell neoplasms, we use CD19 targeted CAR. So in CD19 is the target used for B cell neoplasm. In myeloma, BCMA is one target, okay, B cell membrane antigen. So when you take the treatment algorithm for myeloma, I give you a rough guideline. So newly diagnosed myeloma defining event, yes, then you should treat. If it is a transplant eligible, how do you assess the transplant eligibility? By fitness, general fitness, age, so and other comorbidities. Okay, so induction therapy usually we do use a triplet. Okay, if triplet, then plan for early transplant after 3 to 4 cycles. You plan for early transplant with high dose melphalan and stem cell transfusion autologous rescue, then followed by after 3 months you start go for a maintenance. So depending upon the high risk or low risk myeloma by the baseline prognostication of the fish, you decide either you can do a bortezomib based maintenance or you can give a lenalidomide based maintenance. If there is no response to the primary therapy, then you have to go for a salvage regimen. You have to change. If you are using a triplet containing bortezomib, lenalidomide, dexamethasone, you can change it to vorticyclodex, or you can upgrade to carfil, pom, dexamethasone, like that. Okay. So depending upon what all the patient is responsive to, if that patient have failed on a IMID, then you have to consider other group of therapy, right? Then that's how you decide. And if it is a transplant ineligible due to reasons like elderly or you have an unfit patient, then you trim or tailor the treatment accordingly, right? So response after primary therapy, if they are eligible, do autologous transplant. There is something called, you can do a delayed transplant also. Like if you do 3 to 4 cycles, you achieve a remission, then you can do autologous transplant immediately, or you can cryofreeze the stem cell, because if you are giving a lenalidomide based therapy, if you give for more and more cycle, the mobilization of stem cell in future may be difficult. So what you do is like cryofreeze the stem cells then, and then continue with the at 10 to 12 cycles of the chemotherapy, and at the time of relapse, then do salvage and then plan for transplant at that time. So early versus late transplant. So this is what is mentioned here. So response after primary, either you go for autologous transplant, and if there is this response is enough, then go for maintenance, either with a bortezomib based or lenalidomide based, or if progression, then go for salvage regimen. So or you do continuous myeloma therapy. If not going for transplant, just do freezing of the stem cells, and if progression, do salvage, then plan for transplant at that time. So late autologous stem cell transplant. Tandem transplant in very high risk patients like in 17p and all. Again after that, if there is response, that like this maintenance therapy. So high dose therapy with autologous. So basically, for example, if we have a myeloma, say 50-year-old myeloma, okay, he underwent a VLD based, V meaning Velcade, that is bortezomib, lenalidomide, dexamethasone. Okay, so 3 to 4 cycle, we achieved a say VGPR, say 96% reduction, 95% reduction you have. Then we plan for a autologous stem cell transplant. So autologous stem cell transplant, you have to understand that this is a patient's own stem cell is used. So what we'll do is, autologous stem cell transplantation, mainly the purpose is to consolidate the disease. Okay, so this 95% reduction, meaning if you look at the marrow, morphologically it may be in remission, but there might be some myeloma cells which can relapse eventually, right? So autologous stem cell transplant is for that. So autologous stem cell transplant is otherwise called high dose therapy followed by stem cell rescue. Okay, so what we do is we achieve VGPR, then we do collect the stem cells. Okay, because with the disease nobody will collect. So stem cell apheresis. So what we do for stem cell apheresis, peripheral blood collection is used. So we give GCSF. Okay, GCSF to the patient. So what will happen with GCSF? The hematopoietic stem cells, that is CD34 stem cells, will start circulating in the blood. So we harvest that stem cell, right? How do we harvest? During a peripheral blood collection, just like a blood donor collection, SDP collection, we do collection from peripheral blood. So the circulating stem cells will be collected in a bag, right? So this is kept like this. It can be kept in 4 to 8 degrees Celsius for like 72 hours. This is kept in the blood bag. So then we do chemotherapy. Okay, so we have kept aside the stem cells, right? Then we do chemo. It is like a IV infusion, right? Chemotherapy. So what will the chemotherapy do? It goes and kills the whatever residual myeloma cells in the marrow, right? But this is very high dose. What will happen with the high dose? Bone marrow will go into aplasia, right? Good cells, bad cells, everything will be gone. So the recovery is very delayed. It can even prolonged cytopenias can land up in aplasia. Then the patient might be lost in due to infection, right? So what we do is this stem cell we already kept is reinfused after giving chemotherapy, because chemotherapy should be given after taking out the stem cells, because if you give chemotherapy all the cells will be gone, right? Stem cell also will be gone. So we keep the stem cell, collect it and keep it in the bags, cryopreserve or not. Then chemotherapy is given as a IV infusion, then you reinfuse back the stem cell so that it go and repopulate the stem cell. So the main work is done by the chemotherapy, which is melphalan. Usually melphalan is the conditioning in. So single agent melphalan is given, and what you call is this stem cell reinfused. So this doesn't involve any operation or anything, surgery or anything. Just keep your stem cells outside, give the chemo, reinfuse the stem cell so that it will go and repopulate and the recovery will be faster. So high dose therapy followed by stem cell rescue. This is autologous transplant. So the job is done by the chemo and your recovery is hastened by the stem cells, own stem cells. So this is much of autologous stem cell transplant. So following, is it done with transplant? No. It's not like you do a transplant and you get 100% won't relapse. It can relapse. So that is handled by the maintenance. So maintenance therapy prolongs the remission following the high dose therapy. Okay, so basically post transplant, either you can do a bortezomib based maintenance every 2 weekly bortezomib, or lenalidomide based this thing. So high risk disease you can go for bortezomib based, or low risk disease you can go for the lenalidomide based oral therapy. And relapse disease, as we said, if it relapse after transplant, then if it is a long relapse, then you can reuse the same regimen used. If autologous transplant not done, you do a salvage, then go for autologous transplant. Even allo has been mentioned in high risk disease or multi-drug therapy, or failed with various immunomodulators, proteasome, everything failed, you can go for allogenic transplant. Then CAR cell therapy, BCMA target, okay, B cell membrane antigen, and or if it is a refractory case, palliative care and all, okay. Then the regimens used for previously treated multiple myeloma, then carfilzomib, second generation proteasome inhibitor, elotuzumab, selinexor, bortezomib based cyclophosphamide, all these are combination triplet regimen, daratumumab, ixazomib. Then in certain circumstances, early relapses, you can even go for other combinations, right? Venetoclax, especially this you have to remember for MCQs. Venetoclax, specific action in 11-14 myelomas, translocation 11-14. Then chemotherapy based older regimens like DTPase, VDTPase, DCEP and all for very refractory myelomas. Okay. Then previously treated multiple myeloma, at least late relapses, more than 3 prior therapies, bendamustine with proteasome inhibitor steroids, and this is the CAR cells, idicaptogene, ciltacabtagene, teclistamab, these are belantamab and all are antibodies, selinexor, dexamethasone combination. So along with that, the supportive care in myeloma, bone disease, primary myeloma should receive bisphosphonate except in renal failure, vitamin D status, dental examination, because with if there is any dental issues, we don't give bisphosphonate because it can cause osteonecrosis of the jaw. So bone targeting bisphosphonate or denosumab. In renal failure, we prefer denosumab, which is a RANGL inhibitor. Okay. Then radiation if needed, orthopedic consultation if there are fractures, vertebroplasty, kyphoplasty if there is severe compression fractures and pain. Hypercalcemia needs to be managed with fluids, hydration, steroids, and hyperviscosity, plasma exchange. Anemia, again erythropoietin and other causes if there is a bleeding, cause to be found out. Infection, again immunoglobulin. If there are recurrent infection due to immunoparesis, IVIG might help, and if IgG levels less than 400. And other vaccinations, influenza, pneumococcal and levofloxacin prophylaxis. Okay. Then renal dysfunction to be managed according to the cause, thromboembolism and risk mitigation and risk stratification, and if needed VT prophylaxis. Especially if you are using lenalidomide and pomalidomide, you have to give. If there is no proven thrombosis, you can go with aspirin, or you have to go for a Novak or a what you call a vitamin K antagonist. Supportive care, if bortezomib, there is chance for reactivation of the virus, herpes zoster prophylaxis. Neuropathy, then subcutaneous administration is found to be better when compared to the IV administration, weekly schedule. Lenalidomide, DVT prophylaxis, aspirin if not a greater risk of DVT, but you may have to other options if there is a thrombus already. Anti-BCMA CAR cell therapy, IV immunoglobulin due to induction of prolonged hypogammaglobulinemia. Okay. So coming to the POEM syndrome. POEM syndrome is acronym, polyneuropathy, organomegaly. This itself can be asked as an MCQ. Endocrinopathy, M protein, skin changes, severe progressive sensorimotor polyneuropathy plus or minus sclerotic bone lesions. Polyneuropathy, but POEM syndrome only a rare subset of that group. Lymphadenopathy, hepatomegaly occur in 2/3, and lymphadenopathy frequently resemble Castleman disease with this IL-6 overproduction. So endocrine in amenorrhea in women, impotence and gynecomastia in women, hyperprolactemia due to loss of normal inhibitory control hypothalamus, type 2 diabetes, hypothyroidism, skin changes, peripheral edema, ascites, pleural effusion, thrombocytosis. So all may not be present because in combination of these can be present. So just remember this chart. The other was descriptive. This is the one go chart. So mandatory major criteria, other major criteria, minor criteria. Okay. Mandatory polyneuropathy, monoclonal plasma cell, usually lambda. This you have to remember. POEMs lambda. Okay. So polyneuropathy and lambda. Okay. These are the mandatory major. Minor other major criteria include Castleman disease, sclerotic bone disease, VEGF elevation. Okay. Castleman, sclerotic and bone lesions and the VEGF elevation. And minor criteria others include organomegaly like spleen, liver, lymph node, extravascular volume overload, edema, pleural effusion, ascites, endocrinopathy, adrenal, thyroid, pituitary, gonadal, parathyroid, pancreatic, skin changes, hyperpigmentation, hypertrichosis, glomerular hemangiomata, plethora, acrocyanosis, flushing white nails, papilledema, thrombocytosis and polycythemia. Other symptoms, clubbing, weight loss, hyperhidrosis, pulmonary hypertension, low B12 values. So all these can be included as options for this MCQ. Low B12, not high B12, diarrhea and thrombotic diastasis. So mandatory major, other major, minor criteria, other symptoms like low B12. So you can remember, you can even by heart this because MCQ may be asked. Pathogenesis, increased circulating levels of IL-1, IL-6, VEGF and TNF. Then TGF beta is lower than expected. Treatment of myeloma may result in improvement of other symptom manifestation, similar in terms lines of myeloma. And plasmapheresis does not appear to benefit. Isolated sclerotic lesion may have resolution of the neurological symptom after local RT, just like in a plasmacytoma. Novel agents and high dose therapy, that is autologous stem cell transplantation in selected patients. Coming to the heavy chain diseases, usually these are very rare lymphoplasmacytic malignancies. So their manifestation will vary depending upon the type of the heavy chain. So there are several named heavy chain disorders. They have absent light chains. That's why they are called heavy chain disorders. Gamma, alpha and mu heavy chains have been described. Okay. So gamma heavy chain, otherwise called Franklin's disease, right? So this basically there is a heterogeneous age group manifestations and different countries. Lymphadenopathy, fever, anemia, malaise, hepatosplenomegaly and weakness. So basically fatigue, organomegaly and anemia and recurrent fever. So associated autoimmune disease, especially rheumatoid arthritis. Most distinctive feature is the palatal edema, resulting from there is nodal involvement of the nodes in the Walde's ring. So this may progress even to respiratory compromise. And diagnosis basically anomalous serum M component less than 2 gram and which reacts to anti-IgG, not anti-light chain reagent. So heavy chain, that is the gamma heavy chain, and usually in both serum and urine. Most paraprotein is gamma 1 subclass, other subclasses have also been seen. So Franklin's disease, subtype of the gamma chain and no light chains, right? So usually palatal edema, that is classical. Thrombocytopenia, eosinophilia, non-diagnostic marrow with increased number of lymphocyte plasma cells, no light chains again. Rapid downhill course, usually rapid downhill course and usually die of infection, but there are long-term survivors on chemotherapy also. Okay, rituximab has been reported to show some efficacy. Alpha heavy chain, otherwise called Seligman disease. The other one was gamma was Franklin, this is Seligman. Most common of the heavy chain, it is otherwise called Mediterranean lymphoma. Again an MCQ, please note this. And disease that affects young persons in parts of the world where intestinal parasites are common. So there is some association with intestinal parasites, especially Mediterranean, Asian and South American. Infiltration of the lamina propria of small intestine with the LPL cells, and demonstrating alpha heavy chain is difficult because alpha chains are they have a tendency to polymerize and appears as a smear rather than a sharp spike. So hyperviscosity is not a common despite their polymerization. Usually they don't cause hyperviscosity like IgM. Then again since the bowel is involved, like small intestine is involved, they can present with diarrhea, weight loss and malabsorption and extensive mesenteric and paratic lymphadenopathy. Respiratory tract rare involvement, usually the histologies can be as a malignant lymphoma. Chemotherapy can produce long-term remission. Okay. Then rarely they can respond to antibiotic, so there is query of like some chronic antigenic stimulation due to some chronic infection. So chemotherapy plus antibiotic. Okay. IPSID, basically this is also a one-liner, it's a infectious pathogen associated lymphoma, that is Campylobacter jejuni, mainly proximal small intestine, resulting in malabsorption, diarrhea and abdominal pain. So there is excessive plasma cell differentiated, truncated alpha heavy chain lacking light chains. Okay. Then early stages antibiotic 30 to 70%, most untreated may progress to LPL or immunoblastic lymphoma. Those patients has to be considered for combination chemotherapy. Mu heavy chain, again mu heavy chain secreted into serum, very rare. Only feature are presence of vacuoles. This you have to remember, presence of vacuoles in malignant lymphocyte, excretion of kappa light chains in urine. So ultracentrifugation of gel filtration, this may not be a routine in your clinical, this is a very rare thing, but it is good to know this, especially for the MCQ purpose. Confirm the non-reactive paraprotein light chain. Tumor cells defect in assembly of light chain and heavy chain assembly is the problem, and thus patients not treated differently from other patients with CLL.